Hello and Assalamualaikum to all our beloved audience of Sinar Daily's Life and Style podcast. So we are here again for our monthly podcast, and I am Dr. Nurhamiza Zulkapeli. I'll be your host as well as your moderator for today's session. So as we all know, this month is the month of colorectal awareness. For those who know or those who doesn't know, so today we are so blessed that we have two esteemed panels to discuss on this matter. We will discuss regarding the risk factor and also the disease, the treatment per se, everything about colorectal cancer. On my left hand side, I have Professor Datuk Dr. Ismail Sagap. He is a well-known colorectal surgeon. He has been dealing with colorectal diseases for the past maybe 30 years. Yeah, about 30 years. And he's the director of Hospital Tuanku Ampuan Besar Tunku Aisyah Rohani, the child specialist hospital in UKM. So welcome to the podcast, Prof.
Thank you.
And on my left, the leftmost is Dr. Ashley Zulkapeli. She is the person in charge. She's a medical officer from National Cancer Society Malaysia. She's the person who's in charge of spreading the awareness, but not only for colorectal cancer. She's the person that you want to find for other cancers as well. So welcome to the show also, Dr. Ashley.
Thank you.
So without wasting any more time, because we need a lot of time to discuss on this colorectal matters, I will just start the ball rolling by maybe Datuk could start to introduce yourself first and followed by Dr. Ashley.
Thank you very much. My name is Ismail bin Sagap. I am a senior consultant, colorectal surgeon from Hospital Canselor Tuanku Muhriz, UKM. Professionally, I am a consultant colorectal surgeon, but I'm doing administrative work as a director at the Children's Specialist Hospital, namely the Hospital Tunku Ampuan Besar Tuanku Aisyah Rohani, Hospital Pakar Kanak-Kanak UKM.
All right, thank you so much, Prof. How about Dr. Aisha?
Okay.
Sorry, Dr. Ashley.
My name is Ashley Faizah Zulkapeli. I'm one of the medical officers at National Cancer Society Malaysia.
All right, so without any further ado, let's just dive into the matter per se. So I will start off with Datuk first, since this is more of his forte. As we all know that colorectal cancer is the second most common cancer in Malaysia, right, Prof?
That's right.
Yes. So maybe Prof would could actually elaborate furthermore, because as we all know, as our past podcast also, when you talk about cancer, we want to know about the incidence. What are the risk factors? Who are actually at risk of getting this cancer? So maybe Prof can elaborate on the incidence in Malaysia and also globally. Where are we in the worldwide itself? Are we more or are we less? And is there any change in the recent years?
The incidence of colorectal cancer in Malaysia is population-wise, it is around 18.9 per 100,000 population. This has been recorded up till 2021 by the Ministry of Health. Through that statistics, it comprises division of among men. It is perhaps the commonest cancer that is happening in our country. For women, it is just second to the breast cancer. Okay. Where we in the global statistics, for those who have higher incidence, they will be at around 40 per 100,000 population. This will be in China, Japan, and perhaps in the United States. We are somewhere in the region of 18 to 20 per 100,000 population. So if Malaysia has got 26,000 adult, for example, 26 million adults, so you can then multiply that for every 100,000 there will be 18 people who will be diagnosed with colorectal cancer.
Right. So we would actually say that it's quite common for us to bump into cases of colorectal cancer, isn't it?
Yeah.
How about the age of the population who are actually diagnosed with colorectal cancer?
Yeah. It's actually a disease of older people, people who are more than 55 years of age are more likely to be diagnosed to have colorectal cancers in our country. But now, globally, there is a trend that it is now inflicting the younger generation. So I will talk about it later, perhaps. The younger, meaning people who are less than 40 years of age are more to be diagnosed nowadays. So we are seeing an increasing trend of colorectal cancer inflicting the younger people.
Okay, I think most of the cancers nowadays, we have seen the shift of the paradigm. It's no longer people always have that taboo or stigmata that, you won't get cancer because it's always will be affecting the older age group. But nowadays, most of the cancer, even the breast cancer, also we can see they are getting younger and younger age, right? So, because we are now seeing even younger adults getting diagnosed with breast cancer, Prof, what are the main risk factors and why it is happening? Can you just maybe elaborate on the specific groups of patients?
When we are talking about risk, we always talk about statistics. Yeah, among the colorectal cancer, we see a pattern of who are the people who are at risk of colorectal cancer. One particular risk that I notice, perhaps, people. It's lifestyle. People's lifestyle. Obese people are more likely to get colorectal cancer. So in the population of colorectal cancers, you see that plenty of them are in the obese category. That is one. Maybe it's their diet, but maybe it's their binging of food. I'm not sure. Or maybe living a very sedentary lifestyle, no exercise. That is one risk. Another prominent risk that we have noticed is that if you have family having any sort of cancer, you might be at risk of colorectal cancer as well, because it is part of a syndrome that you can be affected with colorectal cancer. And then, of course, the habit of smoking, cigarette smoking, and then those people who are alcohol, drinkers, they are also at risk. And there is no particular diet that we can pinpoint to have directly caused colorectal cancer, but colorectal cancers are usually associated with those people who love burgers, processed meat, burgers, sausages, satay, and these are the people who are at risk. And then another two pathological or disease condition that could bring about colorectal cancer. One is what is called inflammatory bowel disease. And if you are diagnosed to have inflammatory bowel disease, it is associated with colorectal cancer eventually. Another disease condition, it is called polyp in your colon. If you have polyps in your colon, then you are at risk of colorectal cancer.
Right, so those are the risk factors. As we all know, most of the time, I think we can actually conclude smoking, alcohol, processed food usually are linked to a lot of other cancers as well. So let's move on to Dr. Ashley. Since we have talked about the risk factors and regarding which are the certain groups which are higher risk of developing colorectal cancer, maybe you could actually share what are the initiatives and also the campaigns that NCSM has done to educate the public about colorectal cancer, because maybe most of the time in the hospital we get patients who are already diagnosed, or the patient who have symptoms or maybe complications, obstruction and bleeding. But when you go out and do your campaigns and your awareness programs, do you think that the Malaysian society, where are we at the level of awareness actually? Do they think the public is aware of colorectal cancer?
Yeah. Okay. So in NCSM we have three main pillars, actually, objectives. The first one is educate, second is care, the third one is support. So when we're talking about increased awareness, campaigns, initiatives, we focus on the two pillars, educate and care. So educate wise, we through various social media platforms, we actually colorectal cancer awareness month, like this month, we post up infographics, awareness videos on various social media platforms by medical officers, for early detection and prevention. As of last year, 2024, we actually reached up to 1 million. This is how we count based on the website traffic and social media traffics and everything. So people nowadays are looking forward. They want to learn about these things. It's just that our responsibility is to feed them with these useful videos. So that's one of the initiatives. The other initiative would be this year. We have done this for many years, but this year we have this campaign called ODOP, so One District, One Program, where we want to touch each district in Malaysia with our program that's called Jejak Cancer. So Jejak Cancer is a free community cancer screening. We do breast screening and everything, and one of them would be colorectal cancer screening. So that's what we're hoping for, each district, at least one program. Last year we touched down over 400 locations. So meaning that we've served 400 communities, kampung orang asli, low income housing areas, religious practices sites and things like that. So those are the two big campaigns that we do for colorectal cancer.
And this would include Borneo as well, like Sabah Sarawak?
Sabah Sarawak, correct. Yeah, Sabah Sarawak.
Okay. All right, so that's a very noble thing that they are doing. You guys can check it out on NCSM Instagram or Facebook. I'm pretty sure, because I also followed them on Instagram. They have a lot of pop-ups and also stories, as well as also campaigns on their Instagram. So moving back to Datuk, okay, so since you already know which group are at risk, the next that they want to know is that what are the early signs, since some patients are elderly, some patients are younger, right? So what are the early warning signs that should prompt someone to see a doctor? What we usually say in cancer is the red flag signs.
All right. The early signs of colorectal cancer, when you have alteration in your normal bowel habit. What is a normal bowel habit? If you used to pass motion, for example, once a day, that is normal. Maybe if you have diarrhea, you could get up to 6 times a day you pass motion, but that is probably due to an infection. But for no reason, if you have alteration in your bowel habit, for example, like 1 month ago, my bowel habit is once a day. But now my bowel habit has become, after 1 month, persistently, it has become 3 times a day without any other symptoms. So that is a warning sign that something is going on in your colon. And the most important thing, that you have to find out whether you have cancers or not. That is one. The other thing, a red flag sign about having colorectal cancer is passing out blood through your stool. A lot of people just brush it away. This could be what I ate yesterday, or a lot of Malaysian, especially, or people in this region, they would attribute that to buase or hemorrhoids, which is a very dangerous attitude towards colorectal cancer or towards PR bleed. So we in UKM, we have done a survey and a research that people ignore these signs for a period of 13 weeks on average before they are diagnosed to have cancer. 13 weeks. That will be a very long time, and perhaps you have gone into a duration whereby cancer treatment will be delayed for that purpose. And then the third signs, and they usually come in combination: rectal bleed, and then altered bowel habit. And the third one that could come into play is, for no reason, you lose weight. You lose weight without having vigorous exercise daily, or for example, or you lose your appetite. This is also a warning sign that something is not right about yourself, and coupling it with the bleeding through your stool, and then the alteration in bowel habit. That is, I would consider these three signs is the telltale sign of colorectal cancer. And then when you have these signs, and then you start thinking, who in the family having the same problem, or anyone in the family having cancers for that matter, then you must start thinking that you might have cancer in you.
Okay, so we have listened to what are the warning signs that the patient should actually come to the hospital if they have, like for example, rectal bleeding, they have loss of weight, as also they have altered bowel habits. But how about those patients who are asymptomatic? Okay, so what are the tools that they can actually get that? So how do they get themselves screened? For example, like what we see in breast cancer, most of the time we have the mammogram. For cervical cancer, we have the pap smear. How about colorectal cancer? We have heard a lot of about fecal occult blood. We have known about colonoscopies, and also nowadays we have the CA, the tumor markers, which I think most of the basic screening tools, basic blood taking, has also incorporated this CA. So what do you have to say about this, Prof?
Well, in the medical field, usually the screening tool are divided into the non-invasive one, and to diagnose a colorectal cancer, you need the tissue diagnosis. Then you will go into the more invasive to diagnose it. So for the population who are for the people who are asymptomatic and they want to screen themselves, the tools would involve, you can check your stool, you can check in the stool, you can check for blood in the stool, you can even check for the indicator markers that says that you have polyps, or at least you have cancers in the stool. There are more and more kits from checking the stool now, which are more sensitive to diagnose colorectal cancer per se. These are the non-invasive screening tools. But if you just check blood can be caused by many diseases as well, like inflammatory bowel disease, and you can have blood from an infection, for example.
So they can have false positive.
They can have false positive results from that. And then a more invasive one will involve checking your blood for tumor markers, and nowadays they can even check your blood and do a genetic screening for colorectal cancer. But those are invasive, expensive, and not necessarily sensitive. And then the gold standard for diagnosing colorectal cancer is actually performing endoscopy, colonoscopy, or sigmoidoscopy, and to actually visualize the lesion, and then take a tissue biopsy and send to the lab, and then diagnose it under the microscope.
Okay, so this is what we call the colonoscopy. In most of the, most of the hospital will have this, what do you call the services, and but some patients, they are afraid to go for colonoscopy. They would do anything else, but when it comes to colonoscopy, as we have heard just now, colonoscopy is some sort of the gold standard. Not some sort, it is the gold standard. It is the diagnostic tool for us to diagnose a patient to have a colorectal cancer. So how do you reassure from your experience, Prof, since you have done thousands more, I think more than that, of colonoscopies, how would you actually give the reassurance, because we have to tell them what are the possible complications. So how would you actually deal with their fear?
Actually, the most important is to educate and counsel them that it is just like it is an invasive procedure, and it is a safe procedure, and you need colonoscopy to diagnose your cancer. We counsel the patient that it won't take perhaps 20 minutes to perform under expert's hand, and the fear is about getting complication from the colonoscopy procedure. Complications rate for colonoscopy is actually extremely low. It is less than, I would say, 0.5% of all colonoscopy that is being performed all over the world. So yeah, complications do happen. It is a procedure not without complication, but it is extremely low and safe. And the other fear is that, is it painful procedure? You can do it without painkillers. You can do colonoscopy even, or sigmoidoscopy even without painkillers and sedation. But most of the time, the patient prefer some sort of sedation, not really anesthesia. But you can also do colonoscopy under anesthesia.
Right. Okay. So, what would be the age that the patient should be start? I mean, if they want to get screened.
If you suspect it runs in the family, so the age to screen the normal people in the family is 10 years before the youngest person in the family that is afflicted by the cancer, 10 years before. So let's say, for example, one of your uncles have at the age of 40, so you should be considering doing it for yourself at the age of 30. But in the normal population, we take 50 years of age is a good age for you to screen if you are healthy and you don't have any symptoms. But the moment you have the symptoms, you should get yourself screened, or at least tested, or at least investigated immediately.
And if you have done it, for example, in a normal healthy person, if they have done it once,
Yeah.
normally what we know that they don't have to repeat it like every year. Like
Yes.
like mammogram, you have to repeat every 2 years. But for colonoscopy, once you have done it, if you are totally normal, then next would be 10 years
10
after
years,
that, right? Because it's not something that grow overnight. So that's what the patients out there, and so the audience out there should know. Yeah. So moving on to Dr. Ashley, what the screening tools. So we want to know, since colonoscopy is mainly in a hospital base, yeah. So does NCSM offer the screening programs for the colorectal cancers also, and how do these people out there, the audience there, can access them? And is it free of charge? Is it with some cost? Yeah.
So we do have a screening tool for colorectal cancer. So it's the FOBT test. So it's a stool test looking for the blood. So we collect stool sample. We are an NGO, so it's a free FOBT kit that we give to patient asymptomatic, 50 years and above. We have that in our community program. So whatever that you see NCSM is doing community outreach program, free jejak cancer, then you can join us and get your kit there. But you can also come to our clinic at NCSM KL, Kampung Baru. Then you can have your kit for free there. And we send the test to the lab, and we also give the result back to the patient.
Okay, so if it's positive, for example, the FOBT is positive, then you would provide a letter, or how
Correct,
how
yes.
do how does
So-
the patient would go to the hospital then?
Yeah, so we will send the result to the patient. If it's normal. If it's abnormal, one of the medical officers will reach out and give a referral letter to the clinic kesihatan or a private surgeon, up to the patients. Yeah.
All right, now we have come to the core, which is once we are diagnosed with colorectal cancer, what is the next step, Prof? I mean, like in terms of the staging, the treatment planning. I mean, what are the key factors that determine their treatment plan?
Okay, once you are diagnosed, you will be counseled by the expert. That is the most important step. You will be told about the treatment strategy. Now, how do we do about it? The first thing for a physician or a clinician to do is to stage the disease. I think everyone knows that cancer has got 4 stages, basically. First stage, stage 1, 2, 3, and 4. Stage 4 is the worst prognosis. Stage 1 is the best prognosis, and 2 and 3 is in between. So likewise, in colorectal cancer, we will stage the disease first. So how do we stage? We stage using imaging and clinical parameters, and then we stage the disease, and then we come to a conclusion to label the patient as stage 1, stage 2, stage 3, or stage 4. And then after that, then the clinician will have a meeting. We call it a multidisciplinary meeting, which involve physiotherapists, nurses, stoma nurses, and then radiologists, pathologists, oncologists, and of course the surgeons. And then we will come to a conclusion and label the patient with only one stage, and then that stage will then guide the team as to how to treat the patient further on.
Right. Okay. So maybe Datuk can touch a little bit on the advancement of the surgery, because we know now it's the hype. The robotic surgery has come into place in Malaysia. So what would you have to say about the robotic assisted surgery as compared to the conventional open surgery? How is that? Is there any difference in terms of the outcome?
Okay. The treatment for colorectal cancers incorporate chemotherapy, radiotherapy, and also surgery. So I am the surgical part of things in colorectal cancer, and you're right. There is a huge advancement in the technology and in the way we do surgery nowadays. And also in colorectal cancer treatment, there is also a huge advancement in radiotherapy treatment and also in chemotherapy treatment. All these combined together will make the survival for the patient and the quality of life of the patient better. Now, I come back to the surgical part. You mentioned just now what is the advancement that is happening nowadays. Nowadays, we are moving from an open surgery to minimally invasive surgery. That is over the last 20 years. We have moved now into from open surgery, which means cutting your abdomen up, open a big window, and then remove the tumor with our bare hands. But now we have moved away from that. We have moved to minimally invasive surgery. At the moment, the technology is just putting in a scope or a camera into the abdomen and using miniature instrument and dissecting the tumor and dissecting the lesion out through a keyhole surgery. We call it a keyhole surgery, but the surgeon is there. It's just that his bare hands are not into the abdomen. Just using instruments with the endoscopes and the telescopes, and then we will just operate. That is called laparoscopic surgery in colorectal fraternity, or in colorectal surgery. That is called laparoscopic surgery. Now we are there now. We are using, in my practice, I'm using minimally invasive laparoscopic surgery in 80% of my cases. So only 20% emergencies and difficult, very, very difficult situation do we use our bare hands and open the abdomen and do the standard open surgery. But from the year 2020 onwards, the minimally invasive surgery now has gone into an era of robotic surgery. Now, what is robotic surgery? Robotic surgery is also minimally invasive surgery using instruments only that goes into the abdomen, but the operator is not there to do the operation. The operator is in the next room. He will be at the robotic console and doing his job without having to be near the patient. The robot will do the things and controlled by a human surgeon which is not near the patient. So you could imagine perhaps in the future the surgeons might not be in the district to perform that operation, or maybe the surgeons might be in another country performing that surgery that is happening in your district. So we are transforming this surgical technique from laparoscopic surgery into robotic surgery. If you ask me, for colorectal services, how many robots are there in Malaysia? I think there are more than 15 robots already into the Ministry of Health, the private and the university hospitals nowadays. I myself, I'm near retirement, so I myself don't have robots in my institution, but we are getting one.
Wow, that's the advancement that we have in Malaysia. Okay. Another thing that I would like Prof to share a little bit. Since we know that surgery is a major part of the treatment, at the same time, we always hear when we talk about colorectal surgery, we also linked it with stoma. So there is often a fear and stigma around the having a stoma. Some patient would actually decline a surgery, and then sometimes the stoma is just a bridge to the definitive surgery, isn't it? So how would you actually advise on patients, and what would be to help them to cope with it physically, emotionally, having a stoma there? Maybe they feel a bit uncomfortable, but what do you have to say in terms of from the medical point of view for the stoma? Intestinal
stoma is something that no one wants to happen to them. Intestinal stoma means you bring out an intestine, and now your stool is coming out not through your anus, it is coming out through your abdomen. That is what a stoma means. So you can imagine a whole series of problems when the patient have the body modified into that situation, where you pass motion through your anus normally, but now you have this bag, which is called, they always call it the bag. All right, and now in Malaysia it is called the bag. So this bag, in our practice for colorectal cancer, yes, it affects not all, but probably around the region of 20% of patients, they will have to have stoma. Now we don't do stoma for no reason. Actually, if you ask a colorectal surgeon, no colorectal surgeon would prefer to do a stoma on their patient, because that would mean that the quality of life of the patient will be very, very low if you produce or if you make a stoma out of them. Now, or you make a stoma to them. This stoma, sometimes it is
necessary.
It is necessary. I regard it as stoma is actually my best friend at surgery. You know why? Because in order to prevent other catastrophe, I have to perform the stoma. But most stoma, I would say 70 to 80% of stoma that we created are temporary stoma. We close the stoma after 6 weeks to 3 months after the initial surgery. We perform stoma at emergency surgery, for example, when the cancer complicated by intestinal obstruction, when the patient is very sick and about to die, then we have got no choice but to perform the stoma. And another area where we perform a stoma is when you cannot escape, the tumor has grown into your anal canal, for example. So you have to take out the anal canal along with the tumor. Now the patient is left without any anus. So you have got no choice but to perform a nice stoma through the abdomen. And then you counsel them and train them how to take care of their stoma. Another area that we have to perform a temporary stoma is when there is difficult surgery. When a surgeon, it is not always easy to perform cancer surgery. When they have difficult surgery, for example, when they are doing the operation, suddenly the heart stops. Suddenly the patient desaturates. Suddenly there is a lot of bleeding. So performing a stoma is a quick way out of the surgery temporarily, and then before we come in again and deal with the matter later.
So basically what I'm trying to say is that the stoma can be temporary. Most of the time it's temporary. Only like certain cases that Prof said, the ones that we have to remove the anus, that it will be a permanent stoma. And having a stoma that they will we can able to reverse it back again most of the time, right, Prof? So, Dr. Ashley, what would you have to say if a cancer is being diagnosed? Normally it's very, very overwhelming. And what kind of the emotional, financial or practical support would NCSM provide?
Sure. So in NCSM, as a cancer NGO, we want to support our cancer patient and their caregivers. So we offer medical guidance, from the moment they're diagnosed. If they not for second opinion, they can speak to one of our medical officers just to guide them along with their diagnosis and treatment options. And then we can talk to them and see what areas they need help with. So we offer free counselling. We have couple counselling as well. We have play therapies for the children affected with colon cancer. We have free dietetic input as well. And then in terms of financial aid, we don't help out with giving money per se, but we help to get them subsidized cancer drugs and also oral nutrition supplements.
Right.
We also have accommodation for free. So they can stay with us while getting treatment at the nearby treating hospital. We call it Rumah Harapan. We have 8 locations, 6 in Kuala Lumpur and 2 in Ipoh, Perak.
Wow, okay. I didn't know about that, but that is a very, very good, I would say, effort from NCSM. Since we are cutting short, like I mentioned, colorectal is such a vast topic. So, Datuk, before we actually end the discussion, maybe you could actually give 1 or 2 advices for the audience out there. To correct some of the taboo, the misconception about colorectal cancer.
All right. Since this is the month of colorectal cancer awareness, month of March, every year we celebrate this as a awareness month. So I would like to urge people to be aware, read more about colorectal cancer, because it is the most significant cancer that is happening around us now. And then the second thing that I would like to say is that once get it diagnosed early, because it is a curable disease. Even if it was stage 4 at diagnosis, we professional in this, we know that it is a curable disease, and let's hope that once you are diagnosed, come forward and we will be able to treat you and make your life better. It's not the end of the world once you are diagnosed to have colorectal cancer. We even can treat stage 4 disease nowadays.
All right, thank you so much, Prof. Maybe Dr. Ashley, before we wrap up the whole thing.
Okay. For NCSM, you can always call our toll-free multilingual helpline 1-800 88-1000. Yeah, so that's a one-stop service phone call that you can ask if you have anyone affected with cancer, yourself or your family members, or you're a caregiver for cancer patients. You can drop us a call or drop us a visit at NCSM KL.
All right, thank you so much to our both panels for sharing with us. I hope it has benefited all the audience out there. To all of our viewers, a few take-home messages. Make sure that you get yourself screened. Second thing is that if you have all these red flag signs, please get yourself please come to the hospital and to get yourself checked up. And also don't be afraid of all the scopes or even the surgery. We have the experts here. You can find the experts all over all over Malaysia. And to all our viewers, don't forget to download the new and improved Sinar Daily mobile applications. Cool new features with fearless and bold content. So I'll see you guys next month. Assalamualaikum. Bye.
You